Since my topic is about the learning the surgical skill, so basically it's very difficult to teach ophthalmology and surgical skill in ophthalmology. There are so many shortcomings in our most of the setups in India, and many a times we don't have any proper setup to teach the students. And with the increasing number of residents every day, we are finding it very difficult. Like I was asking from some of the faculty in AIMS, they told me that there are around 50 residents per year, or almost 50 residents per year, and faculty has not increased in that proportion. The same is with Maulana Azad Medical College, and here in Allahabad also we have 13 candidates to teach, and the faculty remains the same. So it has become a big problem now to teach each and everything, and with the instruments coming up with such a rapid pace that most of our medical colleges, they don't have all the equipments, and even if they have just one, like one or two fake emulsification, some of them. Many others don't have. In the past, we used to get all the training of comprehensive ophthalmology, doing intracapsular cataract surgeries, doing squint stoses, and DCRs and glaucoma surgeries, and even encerclage for detachment. So we used to do almost everything, and our teacher used to do. But that was there in good centers. In not so good centers, you don't have even a slit lamp those days. So you have to learn. I used to go to RP center because it is nearest to me. Those days we never used to have fellowship, but somehow I learned so many things from RP center. And most of us normally examine the patients by torch. Slit lamp examination is almost forgotten. So basically what we require today is for training these fellows and residents is good setup. High volume center should be there, but too much a high volume is not good for any center. Like then the teaching suffers a lot if there is too much of work and there is no classes held. There is nobody to train. Like these days in February we have lots of cases. We are operating around 150 to 200 cataract cases, and residents are of course they also want to do things, but they are tired by the time we start OT. They do workup on 150 cases, and next day they have to operate, and the consultant comes and he says ki yaar jaldi jaldi case lagao, and then we can switch over to the next case. And many times residents don't get cases, and we are at fault with them, and the system is at fault for that. So curricula has also changed today. We have lots of things to learn, not only the surgical training, but we have to learn the topography, the retina, the glaucoma. All specialists are there today in big hospitals, and these fellows are coming. And they many a times I have found that those who are doing one specialty, they don't know even the reflection. So that is also a big shortcoming today. With the fellowships and super specialty developing, people are forgetting to do refraction, and many a times I have found that in amblyopia, people have been doing OCTs and corneal topographies to find out the cause of the diminution of vision. So basic knowledge is very important, and one must attain that knowledge. And surgery gradually picks up. Like in MBBS, we are hardly taught anything about ophthalmology. So when we join as ophthalmologist, as PG student, we find that we don't know anything about cornea. We cannot recognize cornea. Sclera is not clear. Conjunctiva is not clear, and then retina of course is out of bound during MBBS. So many things we don't know. In first year you are as new as you are in first year MBBS for ophthalmology, and at the same time we find that optometrists are working who just know the little bit of ophthalmology, and they know better than the ophthalmologist many times, because first year students, they know nothing. So getting the surgery at first go is very difficult. So it has been found that in United States also, hardly 150 cases they do during their tenure of post graduation, and then they go back to fellowships, and then they learn more there. So it's a long drawn process, and the eye is one such thing that if you get the surgery, you spoil the case, complication occurs, and it occurs more often with the residents. Of course, it occurs in the hands of consultants also, but it occurs more often with the residents. And then once the complication occurs, the vision goes down, and you cut a very sorry figure then. So in many places, even today, People have just done 4 or 5 cases of cataract or maybe SICS or ECC, and they don't have good microscope. So these shortcomings are there. So therefore, the training has suffered. Um, and now working hours, they have lot of work hours. Today in our hospitals, they come at 7 o'clock. I feel pity for our residents and fellows. They work till 9 o'clock, and rather I would say that they are exploited a lot, the residents. Learning does not mean that you start working at 7 o'clock without eating and work till 9 o'clock like a horse, and then you in the end you learn nothing. The whole day you have been working like a machine, doing A scans and looking at the cataract, screening the cataracts only. So therefore, the learning process is very very bad in our setups. And when they, after doing their MS, when they have not done anything, they go to a bigger center where there are just 3 or 4 centers in India who can give you cases. But the training there also is suffering because they have a lot of work there, and they also have to deal with the high volume surgeries. So the training in India is really, I'm sorry to say that we have very poor training centers, and the reason for that is that there is lack of space. Number one, trainers are not interested in teaching. Like those who become senior, they cannot train. They don't have patience. They cannot sit for half an hour to teach a cataract surgery. Although these days videos are available, you do a surgery and you show to your consultants, or the best person to learn surgery is your senior resident. A person who is just 1 year senior, he can teach you everything. That younger person has a zeal to teach, and they always find it a very very happy situation to like they become a good teacher. So you have to, जैसे हमने भी पहले बताया कि उस्तादों की खिदमत करनी होती है, तो आपके उस्ताद जो हैं, they are your residents, senior residents, third year residents, senior residents, and those who have less flow of work. If they have too much of work, you can learn from what you can learn from them is just observe them. How, like if you watch a senior surgeon operating, you would think that the cataract surgery is so easy, DSAC is so easy, and giving lasers is easy. But you have to learn from those who are not masters in initial few years. Then gradually you will pick up and you become your master yourself. And as I was telling, there are a high risk of complications. So surgical mastery is it takes time, and we hardly have any wet labs. So for teachers, I always say that my younger colleagues are there. You have to teach the resident how to select a good case. A good, like these days, it's basically the cataract surgery that is being taught, and with a high volume of cataract surgeries, and ultimately people want to learn phacoemulsification and just go away. So in my presidential address in IIRS, I had told that today, like we have an intraocular implant and cataract surgery and refractive surgery society. So today, the ophthalmology has become cataractology. So that is there. And then you have to have the OT time management that lacks many a times, as I have already said. And you must learn before embarking on the surgery, learning about the microscope. You sit on the microscope and you start doing surgery, you will create complications. So it takes time, and you have to wait for your turn, and then only you can learn. And the teacher's job is to, as we were discussing, you have to build and reinforce the residents' confidence. Many a time you get complications, and everybody get complication. Dr. Dada used to say that if you don't operate, you will get no complications. If you operate, you are bound to get some complications. So don't get disheartened. Don't have sleepless nights. And communication with the trainees, with the teachers should be there. And many a times we are just finishing off our work and going back to our residences. So how to learn, as I have said, that your residents, the senior ones, are the best person. You must select a good case in all the kinds. You cannot look at a senior person and do a hard cataract on day one, or a small people you cannot do. So communicate with the attending physician all the time. You keep, many a times I find that the residents don't ask any questions. जब आप ऑपरेट कर रहे हैं ना, तो ऑब्जर्व करना है टीचर को अपने, और ऑब्जर्व करना है उनका हाथ कैसे चल रहा है, कहाँ पे क्या उठा रहे हैं, क्या चाहिए. Many a times, if the volume is high, you keep on managing the OT rather than assisting the surgeon. So first line assistant, the second line assistants, all this is essential. And how to keep your instruments proper, that is also essential, so that you can do and a proper follow-up should also be there. So these are some of the points that you have to take care of. It's both ways, teachers and residents, and we must take care of that, and then you will be a good surgeon. And you wait for some time, you will get your turn. And wet labs are very, very essential. I would request Dr. Namrata to push this point so that we don't start doing surgery on the human beings immediately after getting through in MS.
Thank you so much, sir. That was a very enlightening presentation and lots of key points teaching us patience. Dr. Sabyasachi, sir, any comments on this?
Yeah, I think sir has brought out very nicely all the challenges that there are, and that it's really important to wait for your turn, because it is going to happen. I think some people are slightly faster learners and some people are slightly slower also. So maybe the trainers might want to sort of take that into consideration as well. And of course, the sort of take home message that don't operate directly on humans and look at wet labs and others is really well taken. So
thank you, sir. Dr. Namrata, ma'am, what do you feel about this? Patience is key.
I think sir gave such a excellent talk, and almost everything was covered. It's difficult to say anything, but I think I agree with Sabyasachi that some people have this surgical skill inherently. So they'll start with the first case and they'll do very well. But those who are not having an inherent, you can say sense, some acquire it. So if you fall into the latter category of acquiring it, then you have to do cases. And don't run after numbers. It doesn't matter you've done 5 cataract surgeries or you've done 1 cataract surgery. You do 1 cataract surgery so well that it is for everybody to see. So every cataract surgery that you do or every surgery that you do is a signature on that patient's eye. You have signed on that patient's eye, and you have signed it. So that signature is going everywhere. It is like your autograph. So even if you do a single case, do it well. So that is important. Don't run after numbers, run
Right.
after quality. I think that is
Right.
very important.
Quality is more important than the quantity.
Yeah.
And
And
वो होता है ना, मेस में बैठते हैं तो मेस में कहते हैं आज गुरु हमने 25 सूद दिए, तो ये नहीं करना है,
हाँ.
आपको अपना काम
So
करना है,
I think that is important. And
करके
if you
आइए,
are not,
आइए बढ़िया लीजिए, वो ज्यादा important. And I have always seen that those who are good observer, those who are good assistant, they always start with a good hand, so they can learn faster, and that is a skill. कुछ लोग धीरे धीरे सीखते हैं, कुछ लोग जल्दी सीख जाते हैं. कहते नहीं है करत करत अभ्यास के जड़ मत हो सजान. तो आप अभ्यास करते रहिए, gradually you would become a perfect surgeon, and you will do better. And keep on learning, keep on watching videos, which is very, very essential. And these days you have all the facility of videos, best of the in the world.
one more thing I would like to highlight, and especially for the women ophthalmologists, we tend to have breaks in our, career. And then we tend to think that, we've not done surgery, so how is it going to happen? So it really doesn't matter. You can pick it up at any point in time and you can, start to do it. It's like cycling. Those reflexes never go back. And like sir said, very important to assist, extremely important to watch unedited videos. For 3 or 3.5 years, I give this example because I am and sir is a witness to it. He saw me assisting, not assisting, standing behind the machine of phaco. And I didn't do a single phaco, but I used to stand behind the machine because as a pool officer, you don't get surgeries because it's a research job. So for 3 years, I did not do any surgery, but it doesn't matter. When I did my first phaco, there was no learning curve at all. I just knew what can go wrong, and I cannot live all the complications doing myself, but you live it through other person's complications. You know that you watch so much that you know that if this is going to happen, then how are you going to deal with it? So even if when your senior gives you videos to edit, don't say, what has he given or what I should try to see where did he go wrong, because he will not know where he went wrong. But when you retrospectively look at the videos, my residents will come and tell me you went wrong here. So it's a great learning experience, even to edit unedited videos of your seniors.
And I read Dr. Namrata paper, and in that they said that there are they are developing some slow surgeons, because fast surgeons they cannot teach anything, because वो देख के ऐसा लगता है ना कि अरे यार ये तो खटपट खटपट निकाल लिया, हम भी उसी स्पीड से करें. तो जैसे आपने कहा ना, unedited versions जो है देखना is very, very essential. If you look at them and then you learn, then you'll be a better. क्योंकि जैसे हम लोग 8 मिनट की टॉक देते हैं और AIOS में हम हमेशा लड़ते हैं कि टॉक्स कम करनी चाहिए, क्योंकि 8 मिनट की टॉक में जो बेचारा बताने आया है दुनिया भर की बातें. गौरव तो बहुत बोलता है तो अक्सर ये होता है ना कि उसमें से मैसेज एक आध ही मिल पाता है हम लोगों को। तो वो टाइम जो है लेक्चर का बढ़ा के डिस्कशन, जैसे अभी हम लोग डिस्कस कर रहे हैं, हमारी टॉक से शायद उतना नहीं मिला होगा जितना हम लोगों को डिस्कशन से बच्चों को मिले। दैट इज ऑल्सो वेरी एसेंशियल that you discuss each and every case with your resident and do it slightly slowly to tell them कि भाई देखो आईए का ये जो है इरिगेशन पहले जाना है, फिर एस्पिरेशन को जाना है। अब वो अगर ये सब बातें डिस्कस नहीं होंगी, फाइनल पॉइंट जो हैं, तो लड़के ग्रेजुअली, हम लोग तो मास्टर हो गए, ये डाला वो डाला वो डाला निकाल के निकल गए, लेकिन लड़के को तो बेचारे को समझ में नहीं आता ये क्या जादू करते हैं।
So sometimes, like I'm quoting Dr. Dada, he used to say that if you read 3,000 pages of a book, you will not know about surgery until the person who's actually teaching you gives you 4 tips and tells you you are doing this wrong.
Yes, yes.
You would have read so much, but still you will not know where you've gone wrong. And of course, don't make a side quote also without the recording button on if there's a facility. And always revisit your videos that very day to see where did you go wrong. I think that is important.